today's session is going to be about क्या हुआ है? Now we have to start all over again for the third time. I hope you can hear me. And this is Dr. Fatma from Surgical 2. Assalamu alaikum. I hope you are all well, fine. And today's session is supposed to be about spinal trauma. And this is probably the fourth chapter from your trauma part of your daily unlock. Let us start because we've already lost like half the time, and let's run about it quickly. Spinal trauma. We will go through a diagnostic evaluation and management. Our introduction would sort of tell us that spinal trauma is not a very frequent injury. It is common as it is, but it is not as common as traumatic brain injury or thoracic injury or the fractures and stuff. However, it is a very high cost disability. Means that once a patient suffers this, it incurs great financial burden on the family of the patient and on the hospital setting itself. It brings about a tremendous change in the individual's life, who from a running about, working, playing kind of person would change into a bedridden or limited kind of a person who has to be taken care of by others forever, right? This injury affects males much more frequently than females, and the percentage in male is fairly high compared to females. How much do you think this is? It is 80%. We've already been through that. Spinal cord, it lies within the vertebral column. It's a soft cylindrical structure made of highly organized nervous tissue extending downward as a continuation of the brain, and the together brain and the spinal cord, they constitute the CNS or the central nervous system. And from these two emits the peripheral nervous system, which regulates the function of the rest of the body. Here we see the vertebral column. Here, it's not a straight tube or a canal which houses the spinal cord. It has three different curves in it. The first part here is the cervical curve. This is the most freely mobile part of the vertebral column, and it is 75% exposed on every side. Hence, it is the most frequently injured part of the spinal canal, the spinal column. Here, second is the thoracic region. This is a relatively fixed part of the vertebral column. It is fixed because of obviously the presence of the rib cage and the surrounding musculature makes it quite fixed. Next is the lumbar region, which again is slightly mobile, but it is not as mobile as the cervical one. Then here is the sacral region, which is again fixed. It's fixed between the pelvic bone, it forms a part of the pelvic girdle, and it has practically no mobility. Here you see is the junction between the cervical and the thoracic region. This is the cervico-thoracic junction, then the thoracolumbar junction, and then the lumbosacral junction. These junctions, these imply areas where a fixed part of the spine, fixed part of the spinal column or the vertebral column connects with a freely mobile or a mobile part. Hence, these are most susceptible to all sorts of injuries where the shearing forces during any movement are the maximum. Spinal trauma, it can involve injury to the vertebral column, the spinal cord, or both. And in 50% of the cases, as we've already pointed out, this injury involves the cervical area and these fulcrum kind of areas, which are the junctions between the thoracic, lumbar, and sacral area. One point to take into account here is that as long as spine after injury is properly immobilized, fixed, then evaluation to find the nature of injury or the extent of injury, it can be deferred and delayed. The most important part at this stage is to immobilize it, right? That is one of the principles of treatment of spinal cord injury. Etiology or the causes of spinal cord injuries involved, you can see here it's falls in elderly, road traffic accidents, in general population, in young people it is sporting events, sporting injuries. An older female lot, it would probably be osteoporosis, which predisposes the person to all sorts of injuries, and then conditions like cancer and other metabolic conditions which can cause pathological fractures and result in spinal injury. All these causes, they produce injuries through a different mechanism. Here you can see that a road traffic accident is producing a flexion injury due to extreme and sudden flexion of the neck in this person. Right here you can see that a fall and strike of the chin on a step, it produces extreme sudden extension of the spine, resulting in an extension injury. In this picture, you'd see a diving person who hits his head on the floor of the pool and as a result suffers a compression injury, right? A compression or shattered vertebral body in this case. Here you see a person falling off the horseback and it has resulted in a twist, an element of rotational and flexion injury together. All these injuries make the others, and you see if there is a hanging of any sort, it results in distraction injuries. All these injuries put together can result in different forms of different patterns of injuries, but when they present with something called spinal shock. And what is spinal shock? It is a state of lucidity, a loss of all reflexes immediately below the level of the injury, resulting immediately after injury, right? When there is injury, the immediate response of the spine is that it kind of goes into shock. And all the reflexes and activity below the level of the injury, it is sort of given up, right? It can last from seconds to weeks, and it doesn't mean that the spine is injured forever that way. Only when the spinal shock has passed can you actually judge the amount of injury, actually see the extent of injury. Once the bulbo-cavernous reflex is over, the spinal shock is considered to be over. Now we look at classification and types of injuries. Classification can be done one depending upon the phase of injury. Spinal injuries can be primary, or the injury which occurs at the time of injury, direct injury. It can result from fractures, dislocations, hematomas, and soft tissue swellings, or secondary injury, which can be due to ongoing mechanical instability. This means that you have not been able to immobilize the patient properly, or it can result secondary to hypoxia and hypotension. These secondary injuries, they compound the initial insult and they cause the extent of the damaged area to increase. Next, these can be classified, injuries can be classified on the basis of injury to the vertebral column. These ये अब क्या करना है? सॉरी, क्यों ये बंद हो गया? मुझे नहीं पता बेटे. अच्छा, अच्छा, Yeah. Yeah. Okay, let's hope we are connected again. And let's go back to the three columns of the spine, which show the instability or stability of the injury. If one column is involved, injuries are usually stable, and if more than one column is involved, the injuries are then considered to be unstable. Okay. Okay, next. Okay, sorry for the interruption, but this net and all that is not working very properly. So, this was the classification of injuries based on the injury to the vertebral column. When we consider injuries directly to the spinal cord, these can either, in very common sense, be complete or incomplete. Complete injury means that there is no function below the level of the injury. That is, no sensations, no voluntary movement. An incomplete injury would mean that there is some sort of functioning below the level, the primary level of injury. Means that either one of the limb may be moving, or there may be some sensation, or there be more activity on one side of the body than the other, anything of that sort. In
की आवाज क्यों नहीं आ रही है? इमरान, ये सेटिंग्स में दे रहे अभी? सेटिंग्स में दे रहे? ये इनकी आवाज कनेक्ट करने में अभी दे रहे? मैं कह रही हूँ माइक सेट करने में दे रहे, इसको म्यूट करो.
ये वो presenters भी यही की चीज़ है. Yeah, thanks. Okay. The level of spinal cord injury determines what the patient actually suffers from. If the injury is from C1 to C6, that is the cervical level 1 to cervical level 6, the patient will suffer from quadriplegia or tetraplegia, which means that there will be uh, paralysis of all four limbs, arms and legs. This also implies that there would be requirement of ventilatory support for the patient because of the paralysis of the respiratory muscles and the diaphragm in this patient. If the injury is from 6 to 8, there will be complete paralysis of the entire body below the level of the shoulder. The shoulder and the upper arm in this patient would be spared, but the hand will be paralyzed and the rest of the body will be paralyzed. If there is injury from T1 to T12, the entire arm and hand are spared, but there will be paraplegia and cases of the lower part of the trunk. L1 to L5 injury would cause there to be paraplegia, which means that paralysis of only the lower extremities. Hands and the trunk would be okay in this case. An injury to S1 and from level S1, sacral 1 to sacral 5 would mean that the patient would be able to walk to some extent with the help of some aid. Here, because you know that femoral, which basically is lumbar in origin, is already emitted and only the sacral segments are left. And the patient can walk around because the extensors of the knee are intact, right? Okay. Next up, we come to some types of incomplete injuries. We are discussing these separately because most of incomplete injuries they form a specific kind of syndrome or set of symptoms and signs that happen in certain patients when a certain part of the cord is injured. We would be looking at the anterior cord syndrome, the posterior cord syndrome, the Brown's cord, and the central cord syndrome, plus the cord equine syndrome. Before we move on to the individual syndromes, let's just look at the basic anatomy of the long spinal tracts, and that would give us an insight into what would be affected and what sort of injury. The descending tracts are usually motor in nature. The lateral spinal-cortical tract is obviously bringing down motor activity from the brain, and there are ascending tracts, which are sensory in nature. There's the posterior column, which is responsible for transmitting deep touch and proprioception and vibration. And there are the lateral and ventral spinal climbing tracts, which are responsible for light touch, pain, and temperature, right? Another thing you take into account at this site is that in any particular track, the topographical arrangement of fibers is such that this upper part of the body, that is the head, neck, are depicted in the most central areas. In the peripheral areas, they represent the legs and the lower part of the body, right? In all tracks, it is kind of that. The upper part of the body is centrally represented, and the lower part of the body is peripherally represented. Henceforth, if there is injury to any of these tracts, if there is injury to the dorsal column, there will be loss of vibration, position, two-point discrimination on the same side of the body. Similarly, if the corticospinal tract, which is a motor tract, is interrupted, there will be paresis, paralysis, spasticity, hyperreflexia, etc. on the same side of the body. But in case of spinothalamic tracts, there will be loss of thermal and pain sense on the opposite side of the body. This is because the spinothalamic tracts they decossage to the opposite side within a few segments of the spinal cord. Right? Thus, if there is injury to the autonomic system, there would be meiosis, ptosis, and hydrosis, right? And if there is injury to that particular anterior horn, there would be paralysis and paresis, hypotonia in that precise segment, not below, in that precise segment, because the segment fed by this area, right? So we're not talking about the tract here. जिस segment में anterior horn cells affect होंगे उस segment में there will be hypotonia, right? Or if there is involvement of the tracts alone, there will be spasticity. Let's move on. First, we come to the anterior horn syndrome. And anterior horn syndrome, it results in, this is the area affected. You can see that the corticospinal tract is affected and the spinal thalamic tracts are affected. The posterior tracts are fine in this case. This usually results from rotation or reflection injuries, severe reflection injuries, this kind of thing. Sudden patient tries to pick up a heavy weight in complete flexion and results in this kind of a injury is kind of like this. There is flexion or compression of the vertebral body, and the canal here is disrupted because of that. This small area, or this teardrop kind of thing, this can actually be on this surface and break into the spinal canal, pressing the spinal cord. Right? The effect is kind of like this. There is loss of motor function with preservation of position, vibration, and touch sense. Yani posterior column की जो features हैं, they would be intact, these. And the spinal thalamic tracts and the corticospinal tracts. Paralysis on both sides of the body and loss of tension and loss of vibration and pain on both sides of the body. Corticospinal and spinal thalamic. It involves full or partial loss of bilateral pain and temperature. Depends on how severe the extent of injury is. Next on, we move to the Brown-Sequard syndrome. This involves a hemisection of half of the spinal cord. This usually results from penetrating injuries. Obviously, it is a very precise kind of thing. Like a fracture where I would not be that precise. It can result from disc prolapse and disc protrusion into the spinal canal from one side. Clinical presentations usually involve unilateral results of unilateral tract damage. If the posterior column on one side is affected, there would be loss of sensations on the same side of the body. If the corticospinal thalamic tracts are affected, which they are, there would be paralysis on the same side of the body. But in this case, as the spinal thalamic tracts are affected, there would be loss of pain and temperature on the opposite side of the body, right? We'll come to that in more detail. It's kind of like this. Loss of pain and temperature on the opposite side. Then we come to the central cord syndrome, which is caused by hyperextension injuries, and it is the most common type of spinal cord. Hyperextension or whiplash kind of injuries are usually a result of road traffic accidents and stuff. This syndrome usually affects the more elderly, older lot of people who already have an element of spinal stenosis and then or pre-existing narrowing of the spinal canal. The effect of this sort of injury is, it being central canal, is that as we discussed earlier, the topographical arrangement of fibers in tracts is such that upper part of the body are depicted more centrally. So in central cord syndrome, upper part of the bodies are affected more severely compared to the lower part of the body. There may also be bladder dysfunction. This syndrome in general has a better prognosis than the rest of the syndromes, and when it recovers, the recovery is from below upwards. Next, we come to posterior cord syndrome. Here we can see that only the posterior cord, the posterior columns, the facialis, cineatus, and gracilis, these are involved. So the patient would lose proprioception, proprioception and deep pressure sense. As a result of that, there will be ataxia and a faltering gait, and sensations of power are usually fine. Such a patient, the ambulation is only possible with visual feedback. This implies the patient cannot walk with his eyes closed, right? He maintains balance by the use of his eyes, by looking at the surface that he's walking on and looking at his limbs as they walk about, right? If he closes his eyes, he's likely to fall down. Then we look at the cardiac venous syndrome. In this case, the injury usually results below the level of the spinal cord. When the spinal cord is finished and this bunch of nerves is going out before they emit out of the foramina, injury to this area results in injury to the nerves. And the symptoms and signs in this case would be kind of lower motor neuron damage, right? Because the spinal cord itself is finished and nerves are being damaged. Usually, patient suffers from pain like numbness and weakness and saddle paresthesia. Paresthesia in sort of this region of the body, cranial sort of saddle region. Okay, next on we move on to treatment of the spinal cord injury. The treatment of spinal cord injuries involves very importantly the emergency management. Then there is use of certain medication. A key element in treatment of it is immobilization. Then surgical management might be needed in some patients, and rehab is what is needed in almost all the patients for a very, very long time. Goals of spinal trauma care, they are to protect the patient from further injury. That is the most important thing in the entire management of spinal cord patient, spinal cord injured patient. Identify the spine injury, it is important, but protection is the most important. Then optimize conditions for maximum neurological recovery. When we first start with emergency management, the first thing is pre-hospital management. When you come across a trauma patient in a pre-hospital setting, the first thing to do is keep a very high index of suspicion in all trauma patients. You should always keep in mind, never forget that there is a very high likelihood of cervical injury in all patients. Just this thing has to go on in mind, never forget it. Then main treatment is basically according to the APLS, ABCD, and B. Maintenance of airway with spine protection, breathing has to be taken care of, chest cage has to be examined, then circulation and hemorrhage control, then disability control. For that, you would have to look into to see if there is normal or abnormal motor and sensory examination, and the reflexes should be checked, and sphincter tone has to be checked. And regarding exposure, when you are examining the back of the patient, you have to keep a log roll in mind to examine the spine of the patient. What is log roll? Let us come to that. All movement, when you're trying to move the patient should be moved as a log would be moved, completely straight with no bends and no twists. See, protection here is the priority, and detection and everything else is secondary to that. For a 70 kg kind of person, at least four people are involved in moving the patient. One holds the head and the other holds the body. Patient is completely straight. There should be no bend anywhere and no twist anywhere during this movement and examination. Next, the neck has to be immobilized and the patient has to be transported to the hospital. For immobilization of the neck in the pre-hospital setting and later on, what we need is a rigid cervical collar. This is called the Philadelphia collar, and this is placed here. This central opening can ensure that we can introduce a tracheostomy or whatever it may be. And this is the hard board with the here the patient's head would be placed, and these would be the second side supports. You can see this here, and the patient is head is taped in a neutral position so that there is no bend and twist during movement and transfer of the patient. At this stage, we have to make sure that before the transportation of the patient, the airway is absolutely secure. If the patient cannot is finding it difficult to maintain airway, the patient has to be intubated and taken care of properly before any kind of transfer is taken into consideration. And before transplantation, everyone at the receiving end should be informed regarding the state of the patient and the time that would be taken for the patient getting there. Coming to the in-hospital treatment, we would go for a system-oriented approach. Once again, there would be ABC, neurological examination, spinal imaging, and then they would be taking care of the gastrointestinal, urinary tract, and the skin. Once again, a primary survey, which will include airway as the first or the primary goal. We have to make sure that there is no respiratory compromise. The airway should be definitely patent. And we have to make sure that someone with an injury above the level of C6 will need intubation and ventilation because they cannot breathe on their own, right? All through this process of maintenance, the hard collar will stay on, the sandbags on the side of the body will stay there, and the tape and the hardwood and etc. will stay there. Oxygen has to be started at approximately 15 liters per minute, right? And ventilatory support, obviously, if needed. Patient has to be monitored regarding respiratory rate, effort, and cough. And if there is an increase in the respiratory rate or difficulty or more respiratory effort, coughing, then we have to make sure that the patient is intubated early rather than late in order to prevent secondary injury that can result from hypoxia. When we come to circulation, if there is an element of low blood pressure and shock, then we have to identify and differentiate between a hypovolemic and a neurogenic shock. Uh, One thing to keep in mind regarding a spinal neurogenic shock is to do not overhydrate the patient. So patient can go into pulmonary edema, and so maintaining the blood pressure at a certain normal kind of level is much better than overhydrating the patient. In this instance, inotropes or pressor agents may also be used. Patients should be catheterized in order to monitor urinary output and see if we are adequately hydrating the patient or not. To differentiate between a neurogenic and a hypovolemic shock, we can look at this table. Neurogenic shock is basically a distributed shock, which means that there is what? There is peripheral vasodilatation and blood cannot actually reach the peripheries very well. This happens because of uh, loss of sympathetic outflow and is associated with injury to the autonomic system, uh, particularly in injuries at above the T6 level. Right, there is 50% loss of sympathetic innervation in these patients. There would be hypertension in both situations, and hypovolemic um, shock. The element was loss of volume, and in this case, the element is loss of sympathetic outflow, resulting in hypertension in both cases. But in hypovolemia, there is an exaggerated sympathetic response because of this element. There would be tachycardia. Here there is again bradycardia because heart has also partly lost its sympathetic drive. Peripheries here are warm because there is peripheral vasodilatation. Here, in order to save blood from going to the peripheries, there is severe vasoconstriction. In this case, because of vasoconstriction, generalized vasoconstriction, and reduction of flow to the kidneys, there would be reduction in urinary output, while here it would be normal. Here the fluids are the treatment, and fluid and blood if it's a hemorrhagic shock. Replacement of blood and fluid is the treatment. Whereas in case of sympathetic outflow loss, you have to replace it. And how do you replace it? By giving something like dopamine. Fluids are given just to replace losses, just to keep the system filled up. Do not overhydrate. Do not overhydrate. Next in our primary survey, we come to assessment of disability. For that, we will see that if the disability is due to an element of head injury, we do the GCS or the Glasgow Coma Score. We will look at the pupils and also do the blood sugar levels to make sure that the disability, plight of the patient might not actually be due to a low blood sugar level. We look for paralysis, paresis, paralysis, sphincter tone, etc. Exposure. Regarding exposure or E, the patient has to be kept warm and this really has to be taken into consideration because anyone who has um, injury above T4, he is obviously going to be vasodilated and will be unable to regulate his own body temperature. Such patients will lose temperature easily and can go into hypothermia very easily. Then we come to adjuncts to primary survey. At the end of primary survey, this is the a little list of things that have to be done by the end of primary survey, right? Full non-invasive monitoring, ECG, trauma series, X-ray series. This will include lateral cervical spine, chest X-ray, and a pelvic X-ray, plus a bedside fast. Um, we should have the nasogastric tube inside the patient. This will prevent aspiration and will also decompress the abdomen. And when we walk through a spinal shock, the stomach would also go into a shock because of that. The stomach also has lost its autonomic nerves, and the gut has also lost the autonomic supply. So there would be an element of palliative IS. Similarly, we have to insert an indwelling catheter because the bladder, having lost its supply, would also tend to cause urinary retention. Okay, these are the X-rays that we have to get done by then: a lateral cervical spine plus chest X-ray plus a pelvic X-ray. The cervical spine X-ray can show us many things with regard to spinal injury. Here you can see subluxation. This is C2 and C3. There is a subluxation between two. Here you can see a fracture, a teardrop fracture of I think this is C5. This is an area X-ray of the lumbar region, which is showing the complete dislocation between L1 and L2. After getting these basic investigations done, we move on to our secondary survey, which is a more detailed examination of the patient. First, we have to get a focused ample history, and I hope you guys know what ample history means. History regarding what? Okay, these allergies, medication, past history, last meal, and the events or its environment, right? Ask the patients if the patient is conscious, which he should be after spinal injury. Ask about the mechanism. Does your neck hurt? Does your back hurt? Can you move your fingers? Can you feel my touch? Right? Ask the patient and then move on to examine. Log roll the patient. In this case, you can see the patient is sitting, but you don't have to sit the patient up. Just log roll the patient and inspect the spine, inspect and palpate it from occiput to coccyx. Look for deformities, gaps and steps. Here you can see a step in the spine at this particular area, right? Look for contusions, lacerations, or penetrating wounds. Palpate the spine and the paraspinal area, the area surrounding the spine on both sides for tenderness, crepitus, and spasm of the paraspinal muscles. Following that, we will have to test sensation, motor function, deep tendon reflexes, the cranial nerves, and then record it completely, and then reassess after a while. We also have to examine the rest of the body to make sure that there are no gut-associated changes. This is the American Spinal Injury Association score, and this form this has to be filled to record the our findings regarding the state of sensations and motor activity in the shown by the patient when we examine. Here is a record of muscles, and this is a record for the terminals. In all, there are 100 points for motor activity, right? And 10 key muscles are examined. We will look at them shortly. And there are 112 points for sensory examination, and 28 dermatomes are examined, right? As at the end of this, we will add this whole thing up to get to a certain net result regarding the state of injury of our patient. These are the muscles that we examine. C5 create deltoid or biceps. This means if the deltoids or biceps are moving, the injury is definitely below C5. If the wrist extensors, that is the brachioradialis and all, they are moving, then sorry, the injury is definitely below C5, C6. If the elbow extensors are triceps, is moving, then injury is below C7. Similarly, For all these muscles examined, we know the exact level of the spinal injury. For example, if knee extensors are moving, the quadriceps muscles, then the injury is definitely below the level of L3, right? And all these muscles for incomplete sort of injuries are given scores. This grading is between 0 and 5. Total paralysis is 0, and 5 is absolutely active normal movement against resistance. The rest is between them. One is just a visible twitch of movement. Two is movement when gravity is eliminated. Three is movement against gravity when the patient is able to move against gravity. Four is movement against some resistance. Five is movement against complete resistance, a lot of resistance. Sorry, I have to go the other way around. When judging the dermatomes or the sensations, grading is 0 to 2. 0 means absent, 1 is impaired, and 2 is normal impulses. And they are checked for pain using a needle and light touch, tissue paper or cotton wisp for light touch. This is the impairment scale. After we have done our examination, a clinical, we categorize the patient into this thing. This is a scale which has A to E, 5 grades, and A means that there is complete paralysis and complete loss of sensation. This is a complete injury, no sensation and no motor function. And E is completely normal with no loss of any motor activity or sensation. Incomplete are the 3 stages between them. B is sensory sensations are there, but motor activity is not there. C is motor activity is there, but it is less than grade 3, which means that it is only if gravity is excluded would it be. Movement is against gravity, but if you add any resistance, the patient will not be able to move. And D would mean that the patient can move against some resistance as well as gravity. After we have finished our clinical examination, the secondary survey, we would move on to the next two secondary survey. This will include a CT scan or an MRI and CVP monitoring. Okay, a CT scan or an MRI is an adjunct to our secondary survey. CT scan will pinpoint spinal trauma, the presence of hematomas, and or bony fragments or anything. You can see here the fracture of the body of the vertebral column, vertebral body, and there's also disruption of the arch. Here you can see a teardrop or a fracture. There's a small part of the body has broken off in transverse section and here in sagittal section. MRI, on the other hand, gives us a much better, beautiful definition of the soft tissues in the spinal cord injury. In all patients who show neurological, abnormal neurological examination, an MRI is a must. After that, disposal of the patient. Patient should be discussed with the spinal surgeon immediately and transferred to the spinal unit as quickly as possible. Now, principles regarding the treatment of spinal injury. These include immobilization, IV fluids, medications, and early prompt transfer. Regarding immobilization, we've already taken steps like giving the patient a cervical collar or a spinal board and log rolling the patient for any sort of movement and examination. These are the collars. This is the Philadelphia collar, the hard collar, and this is the soft collar given according to the requirement of the patient. Further, to immobilize the patient, something like a Minerva cast. This is made of plaster of Paris. This has been used in the past and is still used when required. Then another immobilization device is the halo vest, when these screws are introduced into the skull in order to fix the neck by applying traction or applying an external fixator. Further immobilization and applying traction can be achieved by use of this sort of a sling or applying tongs to the skull and applying traction, right? These are various methods of immobilizing the spine and giving traction. Further, for fluids, we have already discussed this. We have this. Let's move forward. Medications that are given are primarily corticosteroids. There is controversy regarding the use of corticosteroids, but there is evidence to suggest that if given within 8 hours, they do reduce the swelling and limit the extent of the injury the patient has to suffer in the long run. In addition to this, analgesia is also required to keep the patient pain-free during this critical situation. Transfer the patient as quickly as possible to the spinal unit. Regarding definitive surgical treatment, there's a time consideration and purpose consideration. Emergency treatment is required. Emergency surgical treatment is required only if there is an incomplete lesion, short incomplete lesion with progressive neurological signs. Patient has neurological signs like numbness, and they are increasing progressively on, and you want to stop that from happening. You have to decompress the patient immediately, right? Only then an emergency spinal surgery is required. Otherwise, the spinal surgery is elective and can be done within 1 week to 3 weeks after. And the purpose of our surgical intervention is one, to remove deformity, reduce any deformity or subluxation or dislocation that is there. That is one. Then to stabilize and to maintain that reduction that we have done, right? By either by fusion or by inserting hardware. And then we've already talked about decompression, to decompress either to remove blood clot or remove bone or fluid which is pressing upon the spine and making the injury worse. This is the kind of fixation which may be needed. Here the Odentart process of access, it has been fixed by applying a screw in it. This here is a newer thing when a subcutaneous, minimally invasive percutaneous instrumentation is done to stabilize the spine. This is newer compared to open fixation in the past. Following spinal injury, as in case of all other injuries, there are certain complications in case of spinal injury. You already know there is paralysis, loss of sensation, loss of bladder and bowel control, loss of sexual functioning, increased risk of UTIs and stuff. These are the direct complications of the injury. On the other hand, there are complications of the immobility that the injury induces, and these, of course, include DVT and pulmonary infection, skin breakdown, that is stress ulcers, and decubitus ulcers and stuff. There may be contractures and muscle atrophy. All these complications, especially those related to immobility, have to be prevented by long-term nursing care, which addresses muscle spasm, care of skin, bowel and bladder function, and a lot of physiotherapy to improve muscle strength. Patient has to be given occupational therapy. Someone who was a runner might have to be trained to just sit up properly and do some sort of useful thing. And all these patients would require an immense amount of psychological and social support. And at the end, we have to look at safety measures that would prevent spinal cord injuries. See, this would include safe driving, block staircases to prevent toddlers from falling down, check the depth of the pool before diving, wear protective gear in sporting activities, put non-slip mats at bathrooms to prevent falls in elderly, follow traffic rules, wear seatbelts, use helmets, avoid drinking and driving and stuff. And that's it. I hope you guys were with me. Any questions? Thank you for your attention. बच्चे ये हाँ जी प्लीज